Hi, my name is Professor Sauid Ishaq. I'm an interventional endoscopist based at Russell Sewell Hospital, Dudley, UK, and I'm affiliated with Birmingham City University in Birmingham, and as well as St. George's University in Grenada, West Indies. First of all, I would like to thank, on behalf of my co-authors, the editors of GI Journal for accepting our manuscript, Flexible Endoscopic Treatment for Zenker's Diverticulum, a systematic review and meta-analysis. Zenker's diverticulum is a pulsion diverticulum that develops in an area of weakness of the posterior hypopharynx known as the Killian's triangle. Conventional treatment of Zenker's diverticulum is surgical by ENT colleagues, using rigid scope and stapling gun to divide the septum that is made up of caracopharyngeus muscle. This technique, however, requires general anesthesia and neck hyperextension. Division of septum with flexible endoscope using cutting devices is a new and emerging approach, with some advantage over the surgical technique, particularly in elderly and with comorbidities, as there is less need for general anesthesia or neck extension. This was first described by Professor Chris Mulder from Amsterdam, Netherlands, in 1995. Since then, many variations of technique have been reported, and a wide array of cutting devices have been used. Soft diverticuloscope was used in some, and transparent cap was used in the other series. Some even have used argon plasma coagulator to ablate the caracopharyngeus muscles. All of these studies were in the form of small case series, with variable outcome in success, adverse event, and recurrence. There was no clear evidence supporting one technique or device over the other. In 2013, a group of experts met in image meeting in Milan, and we felt that there is need of a systematic review to make some sense what has been published in the past. This has led to this study. The aim of this systematic review is to pool the result of endoscopic treatment of Zenker's diverticulum in terms of efficacy, adverse event, and recurrence. We screened 331 studies, and 41 studies were retrieved and looked at full text level, and only 20 studies that fulfill our criteria were included in the meta-analysis. Despite limitation in studies such as heterogeneity, limited sample size, and retrospective nature of studies, our meta-analysis showed that endoscopic treatment of Zenker's diverticulum is safe and effective, with overall success rate of 91%, a pooled adverse event rate of 11.6%, and a pooled recurrence rate of 11%. This is comparable with the surgical series. Meta-regression analysis for success or safety showed that cutting devices, size of diverticulum, the sample size of the trial, or sedation had no influence on the outcome. What should come next? What are the implications for the future research? Interestingly, regression analysis revealed that the rate of success and rate of recurrence was influenced by the time of publication. Success rate was found to be negatively associated with time of publication, with lower pooled estimate for studies published after 2005, whilst the opposite pattern was found for recurrence. Although this was an unexpected finding, as one expects with increased experience, the outcome should improve, we must emphasize that it should be interpreted with caution because the small number of studies in each group. But other factors may be responsible, such as characteristics of practice setting, expertise of endoscopist, and characteristics of the patient. and all may have influenced the outcome. Such findings underline the need of comprehensive, large, prospective, multi-center studies to validate new technologies applied to Zenker's diverticulum and to pinpoint potential predictors of recurrence. There is also a need to standardize definition of success, relapse, and adverse event. This will surely reduce heterogeneity among studies that will validate further any endoscopic advances. Thank you very much.